Hello and welcome. My name is Heidi Gullett, and I am an Ohio family physician and am thrilled to be with you today, and also thrilled that you've decided to do this quality improvement focus, particularly around HPV vaccination. Both prevention and women's health are very important in my own practice, and so I'm really excited to be on this journey with you as well. I also want to take a moment to thank the amazing staff of the Ohio Academy of Family Physicians for putting this together. They are constantly finding ways to help us as family physicians improve the care for our patients and for our community, and I'm incredibly grateful for all that they do. So I will be joining you for this particular part of this quality improvement program. The HPV vaccination program has multiple pieces to it, and I am speaking to you about the team-based care and workflow mapping. There are a lot of other pieces that you're hearing from my colleagues and some of the live sessions that we'll be able to have with you. So hopefully this will all tie together in a way that you can really envision the improvement in your own practice. So we're just going to talk a little bit about the overall program. So I highlighted, these are the program goals, and I highlighted today that we're going to really focus on describing best practices for team-based approaches to care, as well as performing an assessment in the practice to really identify opportunities for improvement of HPV vaccination rates. All of these numbers are pieces of the program, and so you'll be getting all of these pieces beautifully woven together to help you figure out the best way to improve this in your own clinical context. You'll have some pre-recorded webinars. Obviously, this is one of them, and we'll want you to be collecting some baseline and outcome data. And the incredible OAFP team will be going very specifically over exactly what to do and what you need to submit. But I just put some summary here that we're really looking at percentage of patients 11 to 26 with at least one HPV vaccine, and then the completed vaccine series. And this really aligns with multiple quality metrics. In particular, there's a HEDIS measure around HPV vaccination completion by the age of 13. This is not to the exclusion of also vaccinating those older folks, where there is a newer recommendation for doing HPV vaccination. I do a lot of downstream cervical cancer prevention care in the form of colposcopy, and have done LEAP in the past. And so I see a lot of older individuals who have risk of HPV disease, or they have HPV-related disease. And so we also want you to be thinking about that, but this particular program is very focused on the ages identified here. So today's learning objectives, briefly reviewing the importance of preventing HPV-related cancers through vaccination. That is being covered in depth in other sessions, but we'll just briefly talk on it today. Discuss the importance and best practices for team-based care. And much of this comes from learning that we've done over the years. Many have been presented by the OAFP in the past on other types of cancer prevention, such as colorectal cancer screening, breast cancer screening, cervical cancer screening. And so a lot of the team-based literature out there, not just our local community here in Ohio, but across the country and world, is the benefits of team-based care. And we've tried to pull that together for you on the best possible way in this program. We'll talk a little bit about workflow mapping and the importance and the value. And this is really what ties things to your local context. It really helps you decide what pieces and parts of this are most applicable to your practice and your team, and figuring out what works best in your own workflows. Each of us has a different practice, and so we need to make sure that whatever you're doing works well for all of you and for your patients. And then I put together some key resources. We have a lot of diverse teams across our community here in Ohio. And so I want to ensure that we have a lot of resources available for you, not to overwhelm you in expectations that you use all of them, but to recognize that there are a lot of tools available and you don't have to start from scratch. And hopefully some of these will work in each of your clinical areas. So I don't have any disclosures. I just have a couple graphics here to help remind us where we're at. So obviously that we are all familiar with HPV. If you've been in clinical practice for any length of time, you've seen HPV-related disease in some form or another. But I like to just reiterate that this can happen across the spectrum of gender, and it can also affect multiple areas of the body. Clearly, we often think of cervical associated with HPV, but We know there are other areas: anal, oral, vulvar, vaginal, penile, and actually all of which I've seen in my clinical practice over the years. There's also risk for newborns, and this is much lower risk. You can see here in the middle, there's a pyramid from the Centers for Disease Control and Prevention that looks at the burden of disease. This is from a few years ago. I just want it to be on your radar that recurrent respiratory papillomatosis is also one of those things that does happen, and it is more of a vertical transmission. And so HPV vaccination is critical for preventing all of this. And we just want to ensure that you are grounded with that full scope of understanding of the impact of what you do with HPV vaccination. And then up here in the top right, I just have some information for you just to kind of also ground us in the world. And you can see the massive burden that's disproportionate in certain continents across the world. So certainly it's impacting all of us, and it's impacting nearly every reach of the world. This is the cancer control continuum. And again, this is just a bit of background. It's important to understand where HPV vaccination falls. The cancer control continuum is something that the National Cancer Institute really uses to help us both as clinicians, but also helps researchers ground their focus in ensuring that we prevent cancer from ever occurring, that we reduce the morbidity and mortality once it does occur, and that we care for people once they have had cancer. So you can see this goes from the very beginning, pieces of cancer, what happens at that molecular level to cause cancer to happen, all the way through to survivorship. And so here in this particular area, we are focused in that prevention realm, much further to the left, but you can see that's so critical, because if we're able to interrupt a chain of HPV disease before it ever happens with primary prevention of the HPV vaccine, then we affect all of those downstream outcomes, which is really important. And in family medicine, a lot of times, obviously, we also focus here in this detection area. We do lots of HPV testing via Pap and anal swabs and other things. So it's really important that we also continue to do that. But today, and in this program, we're really focused even more upstream. Also important to recognize, and we'll touch on this today, there are cross-cutting areas across all of this, and those include communications, decision-making, and healthcare delivery. The others are there and also critically important, but in this particular program, this particular webinar today, we're focusing on those other three with the team-based care. So HPV vaccination is cancer prevention. And I think it's been a long time coming in the United States for us to really think that vaccines can prevent cancer. It is also true of the hepatitis B vaccine. So recognizing different types of cancer prevention through HPV vaccine is absolutely critical. And I put a couple different mental models here that you may find useful with your teams and even potentially with your patients. And all of the references that I have here are available via hyperlink in each of the slides so that you can easily find them and you don't spend your time actually searching for them. So HPV vaccination basics, it is essential to cancer prevention, not just at the individual level, but also at the family, community, and population level. And unlike other vaccines, we have really struggled in getting adequate vaccination levels, particularly in adolescents, but also now that we've expanded recommendations in adults. And so I give you here the Healthy People 2030 goal. It is only one quality improvement goal, but it is one that is readily used across the US. And that is to increase the proportion of adolescents or teens who have received recommended doses of HPV vaccine. The goal is also that the American Cancer Society wants us to have that increased goal by 2026. According to the national government, the data that we have for Healthy People 2020 showed that we had just over 54% of individuals in that age range being vaccinated. And that was not a full vaccination series. The goal is that we have people in the teen area, 13 to 15, fully vaccinated 80%, and ideally as soon as possible. American Cancer Society says by 2026, Healthy People says by 2030. But we are a part of that. And as we work on efforts like this, we can do that sooner in our own practices. So you and your team are absolutely essential. So one of the strongest predictors of an HPV vaccination, and to be honest, these data come from lots of different types of vaccination, is a recommendation by the healthcare provider. So the clinician that is a part of that team, if they recommend it, it is one of the strongest predictors that the vaccination will actually occur. And that's true also for teens and particularly for HPV. The most recent data we have from the Ohio Department of Health show that only 62% of Ohio teens ages 13 to 17 have received all of their HPV doses. And as you heard in another webinar, the number of doses depends on the age at initiation of the vaccination dose. So, this is whether they had 2 or 3, depending on when the vaccine was initiated. In the United States, we do know that we have a massive number of newly infected HPV cases every year, and those include adolescents. So what I tell women when I'm counseling them in a colposcopy, a pre-colposcopy counseling session, or when I'm reviewing their results, I say, HPV is ubiquitous. It is absolutely everywhere. And the vast majority of people have been exposed to HPV. We don't obviously know the actual number of cases because we're not doing HPV testing in most men, and we're certainly not catching it all when it's an active infection all the time in women. But we know that there are millions and millions of infections in the US and in countries across the world. And so this particular vaccination is absolutely critical. Some epidemiologic studies do predict that we could prevent 19,000 HPV-associated cancers in females and a little over 13,000 in males through vaccination. And again, these are just based on the data we have, knowing that we likely have an underestimation of the number of HPV infections. So it certainly could even be higher than that. And we also know that HPV is a huge economic burden for our country and also internationally. So in this country, it's thought that the annual burden of HPV disease is about $8 billion. So why team-based care? This is one of my favorite photos that I always use when I'm talking about quality improvement or I'm talking about team-based care. And it's certainly one of those things that I use in my own clinical practice and being in a federally qualified community health center for many years. If we're all rowing in the same direction, wow, we are a force to be reckoned with. And so that is what team-based care is really all about. And whether we're focused on improving HPV vaccination rates or improving cervical cancer or breast cancer, or colorectal cancer screening rates, whatever the focus is, in this particular case, we're focused on HPV vaccination, that team and everyone having a role and everyone knowing their role and feeling empowered to do what is in their scope of practice to help people get the life-saving vaccination is critically important. So we know that team-based care is really relevant for everything that we do in family medicine, but when we're trying to improve processes and improve rates, we really know it's key. And so everyone has something critical to contribute. And I often say, if someone, and I learned this from one of my colleagues many years ago, if a patient or a parent of an adolescent patient connects with one person on that team, whether it be the person who checks them in or the person who rooms them or the clinician or the person who comes in to give a vaccine, if they connect with that person, they're much more likely to trust the care team and they're much more likely to follow through on recommendations, particularly when you have a vaccination series that is multiple doses. So that could be you, whether you're the clinician or whether you're a different part of the team. And we all represent different roles within the process. And each of you watching this likely has different vaccination processes, different workflows. And that's why workplace or workflow mapping is so important, which we'll talk to in a few minutes. And please do not discount your role in quality improvement, in vaccination improvement, HPV vaccination improvement specifically, if you're non-clinical, because you are just as important as everybody else on the team. And you may be that person who helps connect the links that gets them multiple doses and gets it in a timely manner. We also want you to be thinking about parents and patients as part of the care team. And I'm certain you most all probably already do that, but I wanted to explicitly state how important that is. We know, and I know as a practicing family physician for almost 20 years, that there are numerous competing clinical priorities. It is overwhelming often in an office visit, especially when it's a short office visit. And in primary care, we are generalists. We prioritize what needs to be done most urgently. And we also work with patients and their families to ensure that we provide the care that matters most to them as well. And so because of that, sometimes these preventive issues, and particularly primary prevention, come a little bit later or downstream. And we're trying to flip that and ensure that that never gets lost, that every visit is an opportunity for prevention. And particularly in things that may require a bit more of conversation. So they may have heard misinformation. Social media drives a lot of that as compared to a few years back when we didn't have so much to talk with patients about that they didn't see on their social media feed around the internet. And sometimes those conversations you don't have time for in the moment. Everyone on the team can be part of that conversation if they feel comfortable with the content and believe in what we're recommending. So there is a plan among the American Cancer Society to increase HPV vaccination uptake, and there is a great tool that they put together for clinicians. And so I'm going to walk through a few of those steps. It is very straightforward. Clearly, you all probably have thought of these things, but we're just making it explicit. And we're also trying to link you with external resources that help legitimize what you're saying. Not that you aren't enough to legitimize the importance of HPV vaccine, but when it's seen as part of a much bigger cancer prevention effort, cancer scares people, and we're not trying to scare them, but we also don't want them to have to deal with cervical precancer or cancer or anal cancer or penile cancer. None of these things needs to happen. This is fully preventable. So by using these resources, it often helps to tell the story of why it's so important and get it done. So number one, team-based practices. So you want to identify the members of your HPV vaccination quality improvement team. You can call it whatever you want, but we want to ensure that you have people identified. Obviously, everyone in the practice in the care team ultimately will be part of this, but as you're standing something up, it can be really important to have that specific team identified. And I'm assuming that those are those of you who are watching this webinar, but think about who else might not be at the table yet that you need to engage in order to stand up this kind of a QI program. Identify a champion. This doesn't necessarily need to be the clinician on the team or clinicians in the practice. You want to have clinical and non-clinical staff that are really your change agents, those people who believe in what you're doing, who understand it, who can speak with confidence as to why it's really important, and then help get other people to realize why this is such an area of focus for your team. And dental and medical collaborations are also key. So for those of you who have dental practices embedded, so for example, in a community health center where I practice, we have dental as well. I can work with the dentist directly in my practice. When I was in other practices in the past where I didn't have an in-house dental colleague, I would need to work in the community with dentists, but there is a whole area of focus on dentists and HPV prevention. And so working with them is really key. And if you have that in-house, it even accelerates the opportunities for people to potentially get HPV vaccination and the points that they can be reminded of why it's so important, given that HPV affects the head and neck and can be identified during a dental visit. You want to agree to meet regularly and also talk about team tasks. And sometimes this is a negotiation with a lot of competing priorities. But having time, dedicated time to talk about that's really important. And it doesn't need to be an hour or two. Really short, quick, frequent meetings are essential and can be very effective. We are recommending the use of the Plan, Do, Study, Act PDSA process, probably highly familiar to all of you, especially if you've done any of our other OAFP QI programs or you've worked with the Institute for Healthcare Improvement over the years. That is really the key process. We review baseline rates, really important for the team to see that, not just the clinician or the administrator that's part of the team, but everyone, and see what those rates are. I personally tend to overestimate my rates, so it is quite sobering and also quite motivating to see how low my rates are sometimes, and to then set benchmarks and time-associated benchmarks, and then excuse me, and then identify the evidence-based goals associated with that. And then once you have the core team and the change agents identified and you have your data and you know what you're going to do to start your PDSA cycle, you can engage all staff outside of also this dedicated QI team. And important to everybody's buy-in is related to ongoing feedback. So even if people aren't directly part of the team driving this quality improvement program within your practice, making sure everyone has a voice and can help you identify what that next act might be as you do frequent iterative PDSA cycles. And then ultimately, we hope that this becomes part of creating and updating office policies. So it's not just when a particular clinician remembers to talk about it and order it, although it's an important thing that they do recommend it, and that often helps people to accept it, it is also recognized that office policies and standing policies can be key. So here is the PDSA cycle we all know and love. There are many versions of this, but I am in this particular webinar presenting you the one from the Institute for Healthcare Improvement. It is the first one that I began using a couple decades ago, and it has been used very widely in healthcare at all levels. So the micro practice level, the team level, right there at the point of care, all the way up to large health systems. So what are we trying to accomplish? How will we know we've made a change in improvement? That's why the data are so critical. And what change can we make that will result in improvement? And I just want to identify that you can register for your own account at the Institute for Healthcare Improvement website. So that's the ihi.org. And you can access PDSA worksheets and others, but I do know our OAFP team has these resources for you as well. So you can go there if you want to take online courses to learn a little bit more, dive deeper into the science of quality improvement. You can certainly do that, but we're providing you with what you need for this particular program. So step 2, make a plan. Obviously, these are clearly identifiable steps, but walking you through them, identifying opportunities to increase HPV vaccination. That's where workflow mapping comes in, and we will be talking very specifically about that in just a couple of minutes. You want to identify your current HPV vaccination systems and strategies, and if you don't have any, no sweat. We're thrilled you're here, and this is your chance to really focus on creating some or improving the ones that you might already have. Map the flow of your current HPV vaccination process within your own practice context, and this may be that HPV is bundled with other vaccines. Yahoo, that is one of the best evidence-based strategies, is when it is bundled as a teen vaccine bundle. But let's very specifically pick apart how the HPV vaccine process works for you. And that's some of the work you'll be doing here in this program. Share the results with not only the team that you've identified for this particular QI program, but also your broader staff. And remember, engagement of them on an ongoing basis for feedback and buy-in is critical. Determine your baseline vaccination rates. You want to consider the source of your data. So is the source of your data a vaccine registry? Is the source of your data your own EHR? Is it a combination of both? And what is the accuracy of those vaccine data? It is important to know where you're starting, and you want to ensure that you're actually capturing all of those. If you're a practice that has a lot of kiddos move in that may or may not have had it before, you need to ensure that you have the process for uploading those prior vaccinations in the historical context as well. So that's one example of identifying where you may have some holes in the accuracy. Interventions may be focused on the accuracy of the data initially, and that is okay. I mean, we just want you to be able to identify the leverage points for change that are most applicable to you. And then those quick iterative PDSA cycles during the course of your participation in this program will hopefully get you to where you need to be. Then it's moving on to designing your clinic's HPV vaccination strategy and or considering implementation of new evidence-based interventions. And so I have included a number of them. I know my other colleagues who are part of your team in sharing this information with you have also shared those with you. So you can check out these different recommendations and see what might resonate with you, or what you think your team might most want to tackle, or what seems most feasible for you. We do strongly recommend evidence-based interventions, but also recognize that in some cases, you might need to start with an intervention that doesn't have, a peer-reviewed literature behind it, because this is where you are at, and that's okay too. Start where you need to start, and that's a really key reason why workflow mapping is so important. We want you to choose the strategies that are built on your own past QI successes. So is there a place where you recognize the need for your patients or your community and you tackled that previously? Build on that learning and that knowledge and that credibility. You did something really important. So let's take what you learned there and see if we can apply it to this new area of focus. Creating an HPV vaccination policy, as I briefly referenced before, can be part of this. And then I just continue to be that broken record, but incorporating all staff into the strategy design and implementation. So clearly you have a smaller team that's guiding this process, but ensuring you have those access points for input and buy-in from everyone is important. So we have arrived at workflow mapping. I've given you a few resources. We have certainly our OAFP team has put together lots of awesome resources for you. The UCSF Center for Excellence in Primary Care has some great work available publicly for workflow mapping. And the AAFP also has some examples of workflow mapping for different areas. And many of you probably have seen these come your way in emails or in communications from them, but I just give you a couple examples here should you need to, want to dive deeper and get some more ideas. We work constantly in complex adaptive systems in healthcare, really in our lives, but particularly in healthcare, it is complex. Even if we're thinking, oh, I have this, primary care practice and we are a well-oiled machine and we're here, you're still part of this really dynamic, large healthcare system here in the US. And so sometimes things are out of your control. So workflow mapping really helps us narrow down what does our workflow look like at our level, in our context, in our practice? And how do things flow? What do we have control over? What do we think could improve? Where do we think we may not actually have the variables within our control, but maybe we need to change some things around because of that? Workflow mapping helps you figure out what are those mental models that I operate within this complex system. I don't think about that system necessarily every day. I don't think about my mental models for how I navigate through that system every day. I just show up to work and get things done. But the truth is we actually do work in these processes. So this is a chance for you to get it on paper. There's no right or wrong answer, but let's see everyone's perspective from the team about what that workflow looks like, because it may look very different through the lens of somebody working in the front office and somebody working in the back office and then the clinician. We also want you to use these as visual representations. So it can be helpful to talk through your process, but you've got to draw it out. And I am not a very when I draw workflow mapping, it is not pretty, but you know what, it's there. And so just make sure that you're doing this in a way that's a visual representation. And it may be that you use Post-its or other things, but getting it out of your head and out of just verbal and talking about what you see in a pictorial representation is really key for this, because you can then do arrows and sometimes they're bidirectional and you can actually see, oh, this is how it fits together from lots of different perspectives. And you want, as of course, what I just described to be done with your team. And you can do it electronically now that we've been in this era of working virtually. There certainly are lots of things we can do virtually, just like some of these webinars. So you can use virtual whiteboards if you want, little virtual Post-its. If you're together in person, I find it really helpful to just do it in front of us. But I did give you some recommendations also in the resources on how to do it virtually if needed. So these are the steps in workflow mapping. This comes from the UCSF team. Pick a process to map. In this case, we're talking very specifically about HPV vaccination. We want pick which type of workflow you want to use. So do you want to think about the high-level workflow in your practice? So maybe you're a practice where there are multiple clinicians at multiple sites, or do you want to get a really specific micro view in one particular team? And that's up to you. I would encourage you through the course of this process in this program to do multiple levels if you have a larger practice, but that's really up to you to think about what level you start with the workflow mapping. And this is a skill that if you haven't done as a team, you can actually take this and do all kinds of other QI programs using this as well. I personally have done this in the past for colorectal cancer screening, breast cancer screening, and cervical cancer screening in my own clinical practice as well. Number two, determine the beginning and endpoints in the process. What are those? Be concrete about them and identify each step in the process. Be very concrete here. If you need to say, patient speaks to person sitting at front desk, totally fine, do that. And then where does the arrow lead next? Put the steps in order. And sometimes it helps to put the steps on Post-it notes so you can move them around. And you can do that virtually if you want to, or tape, pieces of tape on the wall, etc. Then you want to review and edit your draft, because your first draft is just your first draft, and you got to start somewhere. Just start. Does not have to be perfect, does not have to be aesthetically pleasing. Just do it. It's going to be messy, and the messier, the more effective it may be. And then you want to review the flow chart with the team for input to ensure it's accurate. So you're not going to probably have everyone on the team or everyone in the practice is a part of this. But again, this is a point where people can give input and say, you know what, that's actually not how it works where I sit in this practice. So let me tell you how it works on my end. And that really identifies insights that can be very effective. Here are some tips. And I'm sure you all do this in the very positive cultures that I know family medicine practices have all around our state here. But just as a reminder, maintaining open and constructive environment during the exercise is important. Inevitably, in these kind of exercises, there are hierarchies and power differentials. We typically will have lots of different team members in the room or as part of the team, which is essential, as we talked about earlier. But sometimes people, depending on how new they are or their personality or lots of other variables, may not speak up. And so you want to ensure that there's facilitation that enables everyone to speak up and to give feedback that, no, that's not actually how it works. Can we consider it this way? Or I really think we should start over here. Those are key. You want to focus on the system or the processes, not the people. And this isn't really probably the most important one in my mind. They're all critical, but I think a lot of times in healthcare, things can be challenging. And sometimes the default is that we focus on a particular person who, maybe not as effective at particular things as another person on the team. This is not what we're focused on here. Those are behavioral competencies that need addressed in a different process. We are focused here on systems and processes, and we can be incredibly effective when we think about the system or the process and not the individual people involved. So you want to really think about this irrespective of the actual individuals. You can think about the role, and if you identify some issues with a particular team member as part of this process, that should be handled however you handle those sorts of issues. But I really want you to think about systems and processes in this particular process. Before mentioning a variation of the process, think about whether the event was a one-time occurrence or a habit. So sometimes when we've done this in my practices in the past, we're like, well, do you remember that one time when so-and-so came in and then it went awry? Okay, is that because it one time happens and there was a series of events that caused that? Or is this actually something that's recurrent and it's part of the process or the system that we need to fix? You don't want to go down the rabbit hole of a one-time aberration. You really want to be focused on those systems or processes that occur on a multiple times, regular basis. Map out the process that you currently have. So I fall into this trap often. I'm always thinking about the perfect. And I'm like, this is the process. And in reality, that is not the realistic process that happens in my own practice. It's actually the process I aspire to have, right? Do not let perfect be the enemy of good here. Map out what you really have, as raw as it may seem to you, as flawed as it may seem to you, and that will then enable you to make tremendous growth in improvements. And then use this as an iterative tool, just like your PDSA cycle, your workflow mapping, those are both iterative tools. So once you implement something, you may want to come back to this workflow mapping as your next key to the next, thing that you do. And that will really help move the needle on those baseline to improve data points. All right, so here are some potential evidence-based interventions. You do not, I repeat, you do not need to do all of these. And in fact, you can't do all of them. We just want to give you some ideas. And so think about your own context and what might be feasible and what you might want to tackle based on your workflow mapping, where you currently are, and what your data look like. But here are a few examples. Sometimes appreciating the significance of achieving the rates is important. You know, there may be people in your practice who don't fully appreciate the burden of HPV disease. So maybe that's where you start, with some education around why this is so critical. Acknowledge the importance of your recommendation as a clinician. For those of you who are watching who are clinicians and clinical staff, your recommendation carries a lot of weight. And so don't shy away from that. Remember that it is really important. While everybody's recommendation is important, that clinical one can sometimes be the linchpin, especially if they've heard it from multiple people prior to getting to the clinical part of the visit. Use an effective bundling vaccination recommendation approach. You heard me reference this earlier. Bundling with other recommended vaccinations at the same age. We do it for kids all the time. You know, those babies, those baby vaccinations every couple months in that first year of life, we're always bundling those. So why do we not do that for teens? Well, you need to get your meningitis and your flu and your Tdap. And then if you really want, there's another HPV vaccine that we could give you. No, we bundle it. You don't hide it. You say, this is what I recommend, but it's no different than all of those other adolescent vaccines that are recommended. You want to motivate your team and encourage immunization conversations with parents as well. Implement systems to ensure you never miss a vaccination opportunity. Sometimes standing orders come into play here. Every touch point with the particular team is an opportunity for prevention, an opportunity for vaccination. You want to use partner resources. Make friends with your local health department. I'm a public health doc as well. And so we love partnerships with our local primary care and family medicine partners. Our OAFP is phenomenal with resources, American Cancer Society, CDC, and many others that I've given you in this talk and some that I haven't. Know your vaccination and refusal rates. That's also really important, because maybe part of your cycle here is to dive in, excuse me, to why there are refusals. What is the reason there? And perhaps that's where you target an intervention. Leverage strong clinician-patient relationships to help with those challenging conversations. Trust is a foundation of what we do in family medicine. And so sometimes I have had patients that I have talked with about vaccination for multiple visits, and sometimes over many months and sometimes years. And it may be that day that they then agree to having it done or have their child immunized. Learn how to answer parents' most common HPV vaccine questions. You do not have to have all of this in your head. There are awesome resources for going and finding how to answer some of these frequently asked questions, how to combat misinformation. There are lots of great resources that are evidence-based, so utilize those. You don't have to have that all at the tip of your tongue as you're asked in the office. You can certainly be familiar and then circle back to those recommendations and those FAQs. And then use personal examples of how you chose to vaccinate children in your family. So this may or may not be relevant for you. These, again, are just other evidence-based recommendations that people have studied, but sometimes that works for me. I don't use it with everyone, but I do often have longtime patients who say, well, what did you do for your kids? And so, you know, sometimes that can be really valuable, and you can just talk from your own personal perspective. So that's also something to consider. Here are a couple others. I've mentioned them: vaccinated every opportunity, reminder and recall systems, especially for HPV, because this is one of those things that has multiple doses. Standing orders, I've mentioned over and over. Take part in an immunization registry. Here in Ohio, most of us are part of that as well, but you may have a registry in your own EHR, your own system, depending on what you're using. Review your patient's vaccination histories. I can't tell you how many times I almost missed that, or I do miss it. So making sure that that's part of our routine care, whether they're there for a cold or a well visit. And I know time is a problem. I struggle with that myself, but making immunizations a really key part of what we do, regardless of the reason for a visit, can be life-saving in the end. Schedule vaccination-only quick visits. Make vaccination education a priority for parents, patients, and I would also add staff. Prioritize establishing rapport with your adolescent patients. I have had many times where the adolescents wanted and the parents are a little bit suspect. So those are great conversations. Create a culture that values well adolescent care. Sometimes I have teens that disappear for long periods of time. And so really doing important context and culture for the practice about why you want your teens in, regardless of whether or not they have any urgent issues. Well visits for teens are really important. And then there's a Start at 9 toolkit. So originally when this came out, it was FDA approved at 9, but we often, per the Advisory Council on Immunization Practices, started at, 11. But there's a new effort to push at 9. And so there's a nice toolkit. And so you might want to think about that as well. And this is, these recommendations come from the National HPV Roundtable. Next, engage and prepare all of your staff. We've talked about this a lot, but you want to make sure there's consistent and positive message delivery. You really want to avoid differences in messaging. So it's not the same rote words every time, but you want to ensure that there isn't a staff member who's giving a completely different message. Human interest stories can create staff investment. I have found that it is particularly effective when staff members or patients share their own experience with HPV disease and why they wish they had gotten vaccinated or had the opportunity to be vaccinated and not have to go through that. Not something that I would ever require anyone to do, but oftentimes it spontaneously is shared, and that's really powerful. Identify and openly discuss areas of concern and misinformation. You want to have an open discussion. Consider and discuss methods to address barriers and facilitators to HPV vaccination. And these are often barriers and facilitators to other preventive care, like sexually transmitted infection and contraceptive, but also to other kind of cancer prevention. Sometimes cancer scares people off. So, really identifying what are those barriers and facilitators. And I've given you some links to what some common ones are. You want to prepare your clinical system. So you may need to adapt your EHR. You may be in an EHR that's not adaptable, but you may want to be in touch with IT if you can about what else you might need to do for your particular identified issues. And ensure vaccine supply and storage needs are met. There is nothing worse in my mind than getting someone to the place of accepting the vaccine and then there isn't one to give. That is really hard. So don't forget to check the supply. Prepare your parent or guardian and patient with some targeted education materials. And then the clinicians need prepared too. You're probably not going to have every clinician be a part of the QI team or be your change agent or your champion for this. So make sure that they also have the right tools that they need as well. Finally, the goal is in this ACS plan to vaccinate patients by the 13th birthday. So make an effective recommendation. Recommend HPV vaccine for all tweens and teens between 9 and 12 the same day, and the same way you recommend all vaccines. So if there's one thing you get out of this today, recommend the HPV vaccine for all adolescents between 9 and 12 the same day, and the same way you recommend other vaccines. You want to prompt the healthcare provider. So whether that's EHR or physical reminders that this patient needs a vaccine. If you scrub charts, if you have reminders in the EHR that say this is what the patient's due for, those are great ways to do it. Because as clinicians, we have lots and lots of things in our heads about what we need to do at the visit. And so sometimes just having that physical reminder is key. Increasing access. So again, standing orders, standard procedures. Allowing for walk-ins or immunization-only appointments, very helpful. Track series completion or follow-up. So make sure you know, okay, these are the patients who got 1 and this is when they're due for 2, or depending on when they first got their vaccine, number 3. So make sure you have a way of tracking that. And then measure and improve. Don't forget to measure. We do a lot of great stuff. And sometimes I know my experience has been, I forget to measure our improvement. I think, oh, we've got this now, right? Well, the proof is really in where'd you start, where are you at now? And not to beat yourself up if you're not where you thought you would be with those targets you set, but what do we do to adjust that next PDSA cycle to move in that direction? So have identification of missed opportunities and ways to learn from the processes and systems that you're trying to change. And then the other thing is to make sure your clinicians or your teams know their individual rates. Some people are competitive, and so sometimes even setting up a little friendly competition can be really helpful too. So here are some other resources, vaccination references and resources, excuse me, National Cancer Institute, American Cancer Society, specific to the HPV cancer-free, our local, state, and national health departments, so ODH and CDC. I also gave you some World Health Organization references as well. American Academy of Pediatrics has some great stuff, National HPV Vaccination Roundtable, and Healthy People 2030. So again, I've embedded these links. There is an abundance of information. Don't expect you to use them all, but I want you to be able to easily and quickly go to places that are trusted to find information and ideas that might help you. So together, we can all make a massive difference in reducing the burden of HPV in our communities. And I'm passionate about this, and I know you are too. And I'm so grateful to be on this journey with you. And I look forward to seeing you at some of the live sessions. And in conclusion, just thank you for all you do. You make a huge difference, and not every day you probably don't hear that. But as a fellow family physician and primary care champion in this state, I am grateful for you and every person that's a part of this. So thank you for all you do, and look forward to working with you. Take care.